Hey everyone, today we're going to be looking at headaches. Now, headaches, super common symptom that our patients are going to present with. Now, 90% of your headaches are going to be primary, meaning there's really no pathologic condition that's causing it. However, there's no excuse not to be a good clinician and make sure that this headache isn't secondary to a ton of other pathologic conditions that could be emergencies that we need to deal with. But this video is going to be mostly talking about primary headaches. So we need to remember that really some way we're seeing headaches is going to come most of the time from our trigeminal nerve. So remember, trigeminal nerve, or cranial nerve 5, has both sensory and motor function with the face. We're going to look at more here at the sensory today. So as you can see, there's 3 branches of that trigeminal nerve. We have an ophthalmic, a maxillary, and our mandibular, B1, B2, B3. We get our sensory information from that trigeminal nerve, then goes to the thalamus, and then we interpret that and go on from there. So there is a degree of phys involved here that says that hypersensitization of that trigeminothalamic kind of cortex here, or this pathway here, right, increased sensitization or increased sensitivity of that area can cause a lot of our headaches. More so, the trigeminal nerve can also help release different hyperinflammatories and different peptides and hormones that we're going to cover today that might cause some of these headaches. So the first headache we're going to talk about is a tension type headache, which is by far the most common one. Patients will kind of complain of like this band, like kind of like pressure feeling on their head, usually in the frontal and temporal region. Now, this could be caused by increased sensitivity of the sensory trigeminal nerve I was just showing you, but we don't really know the cause exactly. But super common. This is going to be more mild to moderate pain. This shouldn't be super extreme, and it should not have any of the other signs and symptoms like the other 2 types of headaches we're going to talk about. Usually really treating this is just kind of avoiding different triggers, helping the patient figure out what brings it on, and NSAIDs and stuff like that. Migraines. Now we're talking about a patient that now says, no, my pain is really bad. It's extreme pain, and I also have associated nausea and vomiting with it as well. Now we're going more into migraine pain. Now, migraines in general are more common in women than they are in men. In addition to that, women also might have a degree of hormonal involvement here. What I'm trying to say is some women experience more migraine pain around their menses or right before their menses. So again, just the beginning of the whole cycle. And it actually decreases with women when they are pregnant or in menopause. So definitely could have some hormone type involvement here. Now, there's two types of migraines. We have with aura and without aura. Now the aura, with aura is least common. Without aura is more likely what people see or experience. The other big thing about migraines that we need to keep in mind when we're getting our subjective data is they're going to have this extreme pain, this nausea, can have vomiting, and then they're going to have a degree of photophobia and phonophonia. Again, that is what's going to really keep this type of headache different from the other 2. When we look at the physiology, there's usually some degree of trigger that's causing this. So trigger could be lack of sleep, stress, increased stimulation. It could be alcohol, caffeine, whatever it might be. We know that there are some things that are released. So one of them is going to be our calcitonin gene-related peptide, or our CGRP, and then glutamate, which we know is an excitatory neurotransmitter. We also know there's probably some inflammation and some vasodilation going on up here. We also see low levels of our 5-hydroxytryptamine, okay? So low levels of that and higher levels over here. Well, what we do know is our 5-hydroxytryptamine, okay, one that's acted on, which we'll talk about that here in a second, actually decreases our CGRP and causes vasoconstriction, which is giving our patients a lot of relief. So why not make a medication that does that? And we have, right? So what we do is we work on our 5-HT1B, 1D receptors, and these are what we call our medications called triptans. So triptans work on these 5-HT1B, 1D receptors. They then induce vasoconstriction, hopefully, in the brain, and also decrease our calcitonin gene-related peptides. So very good medication. So when we look at treatment of migraine, some things we want to do is just avoid triggers. So whatever we think might be triggering it for the patient, which they'll know better than us, avoid those. Maybe increased sleep might help. And we also want to do our best to prevent those attacks from coming. So things like beta blockers can help, anti-epileptics can help, antidepressants can help. All these things can help prevent attack from coming on. Now, if attack does come on and we need to abort that attack, we can start with something as simple as NSAIDs or these triptans. So when we look at triptans, major kind of side effects that we're worried about, one thing we can see, which about maybe half our patients see, is this chest heaviness, which they kind of explain a heaviness in their chest and in their arms. The exact cause is not quite known, but it could be from pulmonary vasoconstriction or bronchoconstriction. Now, usually benign, but not to be mixed up with one of the bad side effects of triptans, which is going to be coronary vasospasm. So coronary vasospasm, which would cause chest pressure, that is going to be the same kind of chest pressure we're going to see in acute coronary syndrome with EKG changes. So we worry about that, especially if we're giving sumatriptan or any of our triptans to patients that have a risk for coronary artery disease in general. So those are patients you want to be super careful with or not give this medication to them at all because it can cause that chest pressure that we're seeing with coronary vasospasm. Outside of that, triptans should not be used with patients that are pregnant. Cluster headaches, another headache, more rare, is a type of headache that is going to be more common in men. It doesn't really have any familial increased risk. And it won't have any of that nausea, vomiting that you're going to see with migraine. So that's already helping out your differential. There are some unique things, and we're going to talk about that. So cluster headaches are just that. They happen in a cluster. So you have like 8 in a row in a day or forever long. And then they usually go headache-free for so long. The interesting thing about cluster headache is they're going to have this really sharp stabbing pain. Right? Could be unilateral, could be bilateral, sometimes felt behind the eye or in the temporal region. And why we think it is when we look at our sensory pathways here again of the trigeminal nerve, the ophthalmic region maybe has increased sensitivity. So that's why maybe they feel that pain there, but that's what's possibly causing all that pain here. On top of that is we have a parasympathetic nerve that runs right next to the ophthalmic nerve. So the interesting thing about cluster headaches is they get these autonomic parasympathetic symptoms with it. So that could be ptosis or drooping of the eye, tearing of the eye, increased mucosal congestion and stuff like that. So that is a very unique thing of cluster headaches, which we know might be because of the anatomy here of the ophthalmic nerve and then the parasympathetic nerve running right next to it. Now, treatment for this, sometimes prophylactic things like steroids are helpful. Verapamil has been proven to be helpful. And then during attacks could be something like NSAIDs or, again, bringing back our triptans. That's all I got for you guys. Quick down and dirty today. Much more to that, but I thought I would just do an easy video on it. If you have any questions, let me know. Give me a like. I'll see you next time.